All right, welcome back to another episode. Today we are going to be talking about the vaginal delivery procedure. Per GABS Obstetrics, the goals of clinical assistance at spontaneous delivery are 1. Reduction of maternal trauma, 2. Prevention of fetal injury, and 3. Initial support of the newborn. So today, I'm not only going to teach you how to deliver a baby, but I'm going to walk you through the things that need to be done just before and shortly after delivery as well. I'm also going to review with you the instruments and supplies that you should expect to see on your delivery cart. Before we jump in, I wanted to let you know about a new resource I created for fourth-year med students that just matched into OBGYN and are about to start residency this July. It's called the OBGYN Residency Starter Pack, a 5-step guide for incoming interns, and it's designed to help you feel more prepared and less overwhelmed as you get ready for residency day 1. Whether you're wondering what to review or what some of the best resources are to help you prepare, this guide will walk you through 5 essential steps to help you hit the ground running. It's totally free, and you can download it at subscribepage.io/OB Intern Guide or through the show notes linked to this episode. Now that we've covered that, let's dive in. So you're sitting in the resident workroom, and the nurse comes in and says, "Hey, we need a doctor. Room 10 is about to deliver." So you run over to the delivery room, and when you walk in, you're going to see 2 things. 1 is the patient, and 2 is the delivery cart. Hopefully it's already there. Before we even dive into the logistics of delivering the baby, I do want to review with you what you can expect to see on the delivery cart itself. Okay, items and instruments that you can expect to have on the table include a couple of gowns, the under buttock drape that usually has a big plastic pocket to catch any fluid or blood that comes out during delivery that you don't want to get on the floor. Sometimes you'll have an abdominal drape to cover the patient's abdomen when performing fundal massage as you remove the placenta. 1 or 2 basins or bowls. Typically, one is going to be to put the placenta in when it comes out, and one is just going to have some water that you can use to help clean the patient after the procedure. You'll have a pack of laps, which are the white spongy towels that you're going to use to clear blood out of the vaginal canal as you inspect and repair lacerations. A couple of blue towels, which are usually used to clean the patient after the procedure. A set of Alice clamps, smooth pickups like Russians, tissue forceps, ring forceps, a needle driver, 2 pairs of scissors, 1 for you and 1 for whoever is going to cut the cord, a plastic umbilical cord clamp, and that's going to stay on the baby after the cord is cut, 2 coker clamps or any artery clamp. You'll use these to keep the cord clamped after the baby is detached so that the cord blood doesn't spray everywhere. And that will also help you to apply traction to the cord as you deliver the placenta. You'll have a cup for cord blood and a vacuum container and tube for cord blood collection. So everything on the table is sterile and will usually be covered with a sterile drape, but of note, a vaginal delivery is not a sterile procedure. But the WHO recommends still utilizing a clean technique, and this is still just to mitigate the risk of infection as much as possible, especially because we are often using surgical instruments and sutures for laceration repairs. As of today, the data we have does not suggest that there is a higher risk of infection when a clean technique is utilized over a sterile technique. However, it is still part of some institutional protocols to splash the vulva with betadine or chlorhexidine just before delivery. All right, so now that we know what's on the delivery tray, we can focus on the patient. So the first thing you're going to do when you walk into the patient's room is to go to their bedside and confirm that they are in fact completely dilated. You want to check their cervix and make sure that they are actually ready to push that baby out. Oftentimes, the OB team will be called for delivery when the patient actually still has a ways to go, and you don't want a gown and glove only to realize that she's probably going to be pushing for another hour or longer, so just confirm the check right out the gate. Obviously, if you can see the baby crowning, you can go ahead and skip this step and move right into putting your gown and gloves on. Then, if the patient has a Foley in place, you want to request that that be removed to avoid any trauma to the urethra or bladder during delivery. And next, you're going to position the patient. And typically by now, you're already quote-unquote sterile, so you'll have some nurses or medical students in the room to help you with this. But the patient should be placed into whatever position both you and the patient feel most comfortable delivering in. And that depends on whether or not there are risk factors for shoulder dystocia, whether or not it's a singleton or multiple gestation, and also their anesthesia status. I'd say the most common delivery position you're likely to see in a hospital setting is going to be dorsal lithotomy. And this is because a lot of patients are epiduralized with limited range of motion. Also, hospital labor beds are just designed for the lithotomy position. They have stirrups and leg rests, and the whole foot of the bed can actually be removed so that the provider can stand right in between the legs to catch the baby. For patients with risk factors for shoulder dystocia or multi-fetal gestation, the lithotomy position is preferred because there is more room for us to perform special maneuvers to help deliver the infant. It also allows for increased hip and knee flexion, which rotates the pubic symphysis cephalad and flattens out the normal lumbar lordosis, making it easier to free the impacted shoulder. Once the patient is positioned and the bottom of the bed is broken down, then you're going to take that under buttock drape and slide it under the patient's buttocks. Now you get to the fun part, which is pushing. So I always try to coach my patients on how to push. There are lots of ways to do this, but I'll usually have them push for 10 seconds, 3 times in a row with every contraction. There is no evidence to suggest that this method is any better than spontaneous pushing as they feel the need, but a lot of patients with epidurals aren't going to feel a strong urge to push, and this is just a great way to get started. I'll counsel the patient, and this is pretty much what I say. We're ready to start pushing. I want you to put your hands under your thighs like this, and I'll show them where I want their hands. Take a big, deep breath, and then push. And when you push, I want you to curl over your belly towards me and pull those thighs back towards you at the same time. We're going to do 3 rounds of pushing for 10 seconds each, and then take a break between contractions. Patients can push with an open or closed glottis, whatever helps them to push best. Studies have not shown one method to be superior to another, and in a Cochrane review of 8 randomized control trials, there was no difference in the duration of the second stage of labor, outcome of vaginal delivery, episiotomy, perineal lacerations, 5-minute APGAR score less than 7, NICU admissions, or duration of pushing between open or closed glottis pushers. So really, it's whatever the patient feels comfortable with and whatever seems to work the best. Eventually, the fetal head is going to start to crown, and when this happens, you're going to place a few fingers on the head and apply gentle downward pressure on the head to minimize rapid extension of the head and hopefully minimize perineal and urethral injury. As long as you're not expecting a shoulder dystocia, we typically let the head restitute or rotate externally as it delivers. And this just means that if the fetus is in the occiput anterior position, meaning that the baby is facing down towards the floor as it comes out, it's going to naturally turn either to the left or to the right, and we let it do that. Once the head is out, then we place gentle downward traction on the head until the anterior shoulder is delivered. Then we pull outward and upward on the head to deliver the posterior arm, after which point you can readjust your hands to help deliver the rest of the body. Typically, you'll then place the infant directly onto the patient's abdomen, where her nurses will be ready with lots of blankets and towels to stimulate the baby. Eventually, you're going to clamp the cord. ACOG recommends 30 to 60 seconds of delayed cord clamping for vigorous term and preterm infants. During this time, I'll usually ask the room who wants to cut the cord, and I'll hand the pair of scissors to whoever it is that's going to be doing that. After the baby is detached, then you're going to focus on delivering the placenta. So the ACOG and WHO support active management of the 3rd stage of labor to reduce postpartum hemorrhage. And that involves a combination of a couple of things. The administration of uterotonics, so typically we're bolusing Pitocin, gentle cord traction, and you're using that clamp that's still on the cord to give you some grip on the cord, counter traction against the uterus to prevent inversion. And then as the placenta starts to descend further into the vaginal canal, you can use one hand to apply suprapubic pressure, again to prevent uterine inversion. Right as the placenta emerges, you're going to gently twist the placenta in circles, either clockwise or counterclockwise. It doesn't really matter. This is just to help prevent the membranes from tearing as they deliver. Then you're going to put the placenta in a bucket so that later you can inspect the placenta and the membranes as well as the umbilical cord. 3 signs that the placenta is separating are a gush of blood, cord lengthening, and balling of the fundus. And that just means that the fundus is contracting down, it's becoming harder, firmer, and when you palpate it by the umbilicus, it's going to feel like a hard ball. Next, you're going to inspect for any lacerations and repair them as needed. Then clean the patient and count your laps, instruments, and needles. And there you have it, your procedure's done. So let's do a review. You're going to check the patient to confirm that they are ready to deliver, put your gown and gloves on, make sure the Foley is removed, position the patient appropriately, place the underbuttock drape under the patient, push with the patient, use a few fingers to apply gentle downward traction on the head as it crowns, let the head restitute as it delivers, apply downward traction on the head until the anterior shoulder is delivered, then outward and upward traction until the posterior arm is delivered, followed by the rest of the body. You'll then do delayed cord clamping for 30 to 60 seconds, deliver the placenta, inspect for any lacerations, clean, and count. Quick tips for medical students who are listening. Make sure that you have introduced yourself to the patient prior to delivery. So when you get onto the floor at the beginning of your shift, just ask the residents or attending what patients you should or should not introduce yourself to. You also want to introduce yourself to their bedside nurses and ask them where you can find a gown and some gloves to put to the side so that they're ready for you at the time of delivery. If you're invited to a delivery, act fast. I've had a lot of med students miss out on delivery experiences because they were too slow to put on their gown and gloves. Usually, by the time the doctor and the student is called to the room, things can move pretty quickly, so you want to practice gowning and gloving within a few seconds. Lastly, memorize those 3 signs I discussed earlier that indicate placental separation, because there's a very good chance you're going to be asked that when you're assisting with placental delivery. That's everything for today. I'll see you in the next episode.